Hello, I am Michael Hoke, and today we will go over multiple sclerosis and mimics in two parts. Let's get started with part one, no disclosures. So the resident learner objectives for part one, we will try to decrease our misdiagnosis of multiple sclerosis on MRI by emphasizing definitions, predominantly locations of MS-like lesions. And then later in part two, we'll review common MRI mimics and variants of demyelinating disease. So what is multiple sclerosis? Well, it's an inflammatory and neurodegenerative disease of the CNS, usually affecting young adult women, typically 20 to 50 years old. Don't forget that range is all the way up to 50 years old. You can have from time to time older patients presenting with demyelinating disease, and we'll see inflammation, demyelination, remyelination, and axonal loss at pathology. So multiple sclerosis is a clinical syndrome. As radiologists, we should be supporting our referring clinicians in their attempts to diagnose the disease. We should not be making the diagnosis ourselves. And when you're interpreting an MRI, you should actually look in the patient's chart and at the provided history for these characteristic symptoms and clinical signs. If you don't see these listed in the patient's chart, you should start to think about other diagnoses for the patient. And if you're wondering what Euthoff's phenomenon is, well, it's a tendency for demyelinating symptoms or MS symptoms to worsen in the heat. So there are several criteria to diagnose multiple sclerosis or demyelinating disease. The most well-known is the revised McDonald criteria. And these criteria, they're all created to identify patients at risk for converting to multiple sclerosis after an initial quote, demyelination, end quote, presentation. And they were not created to differentiate from other conditions with white matter spots. So if you think hard enough, you can probably come up with some other etiologies that could fit into the dissemination in space and time criteria, such as vasculitis or embolic infarctions, hemorrhages, or metastases that might have new enhancing lesions or periventricular infratentorial lesions. So now we will go over the definitions of MS-like lesions, mostly by location, to help us not make those mistakes. So the first one are cortical lesions. And you can see here there's a lesion actually in the cortex. And these are important because we have to remember that multiple sclerosis is not just a disease of white matter, but it's also a disease of gray matter. And we need to better identify these cortex lesions since there's a poor correlation of the white matter lesions and the clinical status of the patient. And these are best seen on double inversion recovery images. Juxtacortical lesions are one of my favorite to look for in a MS workup case because these are very specific. And as you can see, this lesion here, there is no normal white matter between the lesion and the cortex. And that is the definition of a juxtacortical lesion. These lesions here are not juxtacortical. These are subcortical. There are lesions here with normal white matter between the lesion and the cortex. So don't use the juxtacortical term unless you can directly see the lesion contacting the cortex with no normal intervening white matter. And again, here are subcortical lesions, not touching the cortex, not in the cortex, subcortical. Periventricular lesions need to be touching the ventricular surface. These are not periventricular lesions. Okay? These are not touching the ventricle. These are more indicative of chronic white matter changes in this case. Again, another case of not periventricular lesions. You can see the lesions on the left. This was initially read at another institution as unilateral multiple sclerosis, but if you take a closer look, these lesions are not specific for demyelinating disease. They're not periventricular or juxtacortical, infratentorial, or cortical. And if you take another look at the flavoids, don't forget to look at your flavoids, we have a steno-occlusive disease on the left, and this was actually a moya-moya pattern in this patient with small strokes in the deep white matter. Another area to look at that's pretty specific for MS are our callosal septal lesions. And you can see these touch the undersurface of the callosum, corpus callosum. And then the lesions on the right are chronic white matter microvascular ischemic changes that are not touching the corpus callosum, and they are not periventricular. Infratentorial lesions, well, when you see these can be in the brainstem or in the cerebellum. And when they're in the brainstem, they tend to involve specific white matter tracts, such as, starting from the top and working down, the medial lemniscus in this patient that presented with hand numbness, the medial longitudinal fasciculus in this patient that presented with diplopia, and the superior cerebellar peduncle in this patient that presented with some ataxia. So you want to look for white matter lesions in specific known white matter tracts, any of the peduncles, any of the long ascending and descending white matter tracts of the brainstem, as opposed to chronic microvascular ischemic changes here, which typically tend to be diffuse, patchy, widespread lesions in the brainstem, not confined to any one specific tract. Another good place to look for increasing our specificity and confidence when we're interpreting an MS study are inferior temporal lobe white matter lesions. You can see in the top row, the patient with the multiple sclerosis has bilateral white matter lesions in the inferior temporal lobes, and in the patient below, in the chronic microvascular white matter changes, which are pretty extensive supratentorially on the axial image, there's a relative paucity of white matter change in the temporal white matter. Moving on to enhancement. So we know enhancing or diffusion restricting lesions are indicative of active disease. And in the flare image on the left, there's several white matter lesions in this patient with MS. And then you could see one of the lesions is enhancing and diffusion restricting. So this would satisfy the McDonald criteria for different lesions in time. And again, one of the characteristic hallmarks of demyelinating disease, if you see it, it's a home run, is incomplete peripheral ring or horseshoe-like shaped demyelination. And in this patient was initially thought to have toxoplasmosis at the outside facility. There's an enhancing lesion that we might see in MS that is, patchy, flame-shaped, ovoid, could be a Dawson's finger type enhancement. And probably because the patient was 50 years old, the person didn't think initially to think of MS as the diagnosis. But if you see there's incomplete enhancement in these characteristic periventricular, juxtacortical, and deep white matter regions, incomplete ring enhancement, that's a home run for demyelinating disease. And just further on peripheral enhancement types, we'll start, if you have complete enhancement in this patient with immunocompromised HIV-related lymphoma, it's usually smooth, complete peripheral ring enhancement in a periventricular distribution. Again, another case of complete enhancement, but this time it's not smooth, and you notice that the inner margin is irregular and nodular. That's more indicative of a glioblastoma. Here's peripheral complete enhancement that's smooth, but we notice that the medial wall, or the wall opposing the ventricles, is thinner. That's indicative of an abscess. And then finally, our demyelinating lesion, where we have incomplete peripheral enhancement, that's indicative of this tumefactive large demyelinating lesion. So when we're reading our MRI studies, we want to look at those common locations that we just reviewed. The white matter tracts of the peduncles and the MLF and the brainstem, inferior temporal horns, our Dawson fingers emanating perpendicular to the ventricles, our undersurface of our callosal septal lesions, juxtacortical and cortical lesions, and of course also our short segment peripheral patchy T2 hyperintense cord lesions. And any MS case should have more check boxes on the left than the right. And if you see strokes, bleeds, cyst, anything else that makes you want to scratch your head, you should think twice about your interpretation. And then once we are pretty confident we're dealing with the case of multiple sclerosis or a follow-up of known multiple sclerosis, we have to remember our Magnum's recommendations for our radiology report and what the clinician wants to see in the report. And we'll discuss, in the report, the lesion number, the size, the shape, what's characteristic of a demyelinating lesion. It's a cortical, juxtacortical, infratentorial, the overall assessment, mild, moderate, severe of our lesion load, And don't forget to talk about brain atrophy, because multiple sclerosis is also a neurodegenerative process. You want to mention any positive or negative imaging features that could be considered as evidence for or against the diagnosis of MS. If there's strokes and hemorrhages, maybe these white matter spots aren't MS and it's really vasculitis. And then in follow-up scans, you want to discuss the number of unique active lesions that are new with enhancement, diffusion restriction, and or any that are larger, okay? And again, don't forget to mention the brain atrophy. This is a 37-year-old patient only, pretty young, with multiple sclerosis, and the volume loss and the T1 hypointensity correlate well with the neurodegeneration. Okay, part 2 of multiple sclerosis and mimics. And in this section, we will focus on those mimics and variants of demyelinating disease. So clinical over-reliance on MRI interpretation in the setting of clinical findings suggestive of, but not diagnostic for, multiple sclerosis may be a major cause of misdiagnosis. We cannot clinically over-rely on an MRI interpretation alone in these patients. So our first variant that we will look at is chronic small vessel ischemic changes, these white matter hyperintensities. And the risk factors for these changes, you know these well: increasing age, female, hypertension, diabetes, smoking, hypercholesterol, and just genetics. And 3% of 40-year-olds have white matter changes on MRI, and that is far more than how much multiple sclerosis affects the US population. Keep that in mind. Our next variant, migraines, headaches associated with white matter changes. And migraines, as you know, are paroxysmal attacks of unilateral throbbing headache and autonomic system dysfunction. It's the etiology for MRI white matter spots in about 7.5% of the US population. Again, that's far more than multiple sclerosis affecting 0.1% of the US population. So keep in mind that chronic small vessel ischemic changes and chronic migraine white matter changes are far more prevalent than MS white matter changes in the general US population. Our next variant is CNS vasculitis, and this is inflammation of the blood vessel walls, which can then lead to occlusion of that blood vessel and result in strokes seen as white matter changes on MRI. And CNS vasculitis can be primary, secondary, and they have some different clinical features than multiple sclerosis, including fever, night sweats, TIA symptoms, and thunderclap headaches. Another good key to look for is involvement of the paranasal sinuses from the vasculitis. And on MRI, you want to look for infarctions, hemorrhage, and vessel stenosis, as we see here on the reconstruction of the MRA. Here's another case of CNS vasculitis in a patient with lupus and antiphospholipid syndrome. MRI lesions typically in vasculitis affect the subcortical white matter, cortical gray matter, deep gray matter, and deep white matter in decreasing order. And in this case, you see lesions in the subcortical white matter on the left, and on the right, you see an infarction of the cortical and subcortical white matter. This could be very confusing, and there's overlap with multiple sclerosis, but these patients have different clinical symptoms, and the volume loss associated focally with the infarction should give it away on the right image. Another mimic of multiple sclerosis is Susac syndrome, and this is actually an autoimmune microangiopathy that's more common in females, and it's usually monophasic over 2 to 4 years. And the classic triad is the subacute encephalopathy, hearing loss, and vision loss from branch retinal artery occlusions. And one of the distinguishing features of Susac syndrome are these mid or central callosal lesions, which, contrasted to MS callosal lesions that are on the undersurface, you really should look for these central callosal lesions in Susac syndrome. And here's a case of Susac syndrome where we see periventricular and subcortical white matter spots, which could look like demyelinating disease, but actually in this angiopathy, they're related to ischemia. And here is a classic enhancing central callosal lesion rather than callosal septal. Again, because this is a microangiopathy, you can see microinfarctions of the cortex, which may cause this leptomeningeal enhancement. And this leptomeningeal enhancement can be seen in up to about half of the Susak syndrome cases, and people think that it could predict future relapses and future brain atrophy. Here's another mimic of multiple sclerosis, CADASIL, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. And this is a gene mutation of Notch3 gene on chromosome 19. And the patients present with stroke and TIA symptoms in young adults and migraines with aura, which is different than multiple sclerosis. And in part 1, we talked about inferior temporal lobe white matter lesions being more prevalent in multiple sclerosis compared to chronic small vessel ischemic changes. But I guess this is one etiology you should keep in the back of your mind for temporal lobe white matter changes, as you see on the left image. Other areas that are classic for CADASIL, in addition to the temporal lobe white matter changes in the temporal pole, would be external capsule lesions and superior paramedian frontal lesions. So clinical red flags to think of a better explanation for white matter spots than multiple sclerosis would be the wrong age, either they're younger than 20 or older than 50, a family history of multiple sclerosis, an abrupt, swift progression of symptoms without recovery, because usually in relapsing remitting multiple sclerosis there is a recovery stage, and patients have different symptoms such as fever, weight loss, pulmonary and GI symptoms, a rash, peripheral neuropathy, and also look for non-multiple sclerosis CNS symptoms such as seizures, hearing loss, and meningitis signs. All right, let's move on to the variants of demyelinating disease. First one here is ADEM, an autoimmune mediated demyelination, usually days to weeks after a viral infection or a vaccination. It's usually monophasic and it can occur at any age and typically has a male predominance. And in this case, there was a patient with a viral URI who then presented with this MRI, and you can see the flare and an patchy enhancing lesion in the right corona radiata. It was monophasic. Follow-up MRI 8 years later shows some sequela of that right-sided lesion, and there was no new lesion developing and no further enhancement on that follow-up MRI. So that's ADEM. Marburg disease, this typically happens in younger patients. They have a febrile prodrome, and it's a clinically fulminant variant of demyelinating disease. And you can see multiple widespread lesions bilaterally enhancing. You know, it could look like a multifocal tumor on spectroscopy. It can also look like tumor since the choline and the NAA are reversed, but we can see this elevated myo-inositol at 3.5 parts per million, which can be seen with the demyelinating process. Baloconcentric sclerosis, another variant of demyelinating disease. It's a rare and severe variant, usually monophasic, and the lesions can be small like this one, or they can be quite large, and you have this classic alternating zone or bullseye appearance of demyelination and myelination of the lesion. Here's another case of concentric sclerosis with the same classic bullseye or target appearance of different zones of myelination and demyelination. Tumefacted demyelinating lesion. Well, these are large demyelinating lesions, usually greater than 2 centimeters, often solitary, but again, they have incomplete peripheral enhancement, which is characteristic of a demyelinating lesions. Another clue would be to look for veins, normal veins running through the lesion on like an SWI image or a post-contrast image, and they usually have little mass effect for the size of the lesion. And also, these lesions are hypoperfusing as opposed to tumors, which are hyperperfusing. And again, this large tumefacted lesion in the left frontal lobe has incomplete peripheral enhancement, which is another clue posteriorly. Neuromyelitis optica, used to be called the Vick's disease, is another type of demyelinating disease, and nonspecific white matter hyperintensities are not that uncommon in NMO, and these patients usually have a wide, thin lesion of the ependymal lining of the ventricle. that lesion that's lining the ependymal lining can show enhancement. And also neuromyelitis optica, when there's optic nerve involvement, the involvement tends to be bilateral or post-chiasmal. So suggestive MRI findings of neuromyelitis optica, you'll have diencephalic lesions, dorsal brainstem lesions, these arch bridge ependymal callosal lesions, wide periventricular spread lesions that we showed on that first image, large lesions following white matter tracts, i.e. the corpus, the cortical spinal tract, and bilateral or post-chiasmatic optic pathway optic neuritis, as opposed to MS, which is usually pre-chiasmatic or unilateral. Another type of demyelinating disease, PML, it's an opportunistic infection by the DNA JC virus, which causes demyelination in immunocompromised patients. And in this case, this is PML related to AIDS, and there's involvement of the subcortical U fibers. And for the size of the lesion, there's usually little to no mass effect, and there's usually little to no enhancement until late in the disease, where you get enhancement at the periphery of the lesion. And these can be solitary or multifocal and large, and without treatment, there's usually death in months. And you can see in this case, there's a large multifocal lesion crossing the corpus callosum, and there's actually volume loss in the left frontal lobe where the lesion actually started, and some patchy enhancement at the periphery. But moving on, what we should keep vigilant for is PML related to immunocompromised MS patients from MS therapy, such as people on Tisabri or these other monoclonal antibodies that prevent lymphocytes from crossing the blood-brain barrier to reduce MS relapses. This increases our risk from PML. And here's a case of a definite MS patient in October of 2012 where there was no lesion in the highlighted area of the yellow square. But moving forward, we could see a year later there's starting to be some flare hyperintensity in the subcortical region. And even further on, a few months later, in 2013, there's even more flare hyperintensity in that paracentral region. And moving forward even further, in February 2014, there's definitely some more evident abnormality in this paracentral lobule in the subcortical and deep white matter. And that's when the red flag kind of went up and said, oh, what are we dealing with here? And unfortunately, the Tisabri was discontinued too late, and the patient died later on. But you can see the final MRI, there's just widespread flare hyperintensity in the paracentral region on the left and some extension to the right. And what we now know is that focal SWI change in early asymptomatic Tisabri-related PML can be seen. And this is that same patient from the earlier scan in 2013, where in the yellow box you can see some subcortical SWI hypointensity that really should tip you off when you see this in a MS Tisabri patient, that this could be developing PML. And you could save somebody's life if you call this. So remember that this new susceptibility in arcuate fibers is sensitive but not specific. And here it is again magnified. So MRI signs of PML for new lesion in asymptomatic MS patients on Tisabri or other monoclonal therapy. You want to look for punctate T2 lesions in a satellite or perivascular distribution. That is the Milky Way sign, and that is pretty specific. If you see involvement of the cortex or ill-defined borders, contrast enhancement at the margins of the lesion, and a large lesion size, you should be concerned that this patient on MS therapy, monoclonal therapy, is developing Tisabri, and you should call your referring clinician immediately. So the take-home points, remember from part 1 and part 2, MS is a clinical diagnosis, not an MRI diagnosis. Juxtacortical lesions need to touch the cortex, same as periventricular lesions need to touch the ventricle. And white matter spots on MRI due to small vessel chronic ischemic changes and migraines are far more prevalent than white matter changes on MS in the general population. So let's go over 3 review questions, and in each case here, we'll see which case is the demyelinating lesion, either A or B. Well, in this case, it's B, because this case has cortical and juxtacortical lesions, which are more indicative of demyelinating disease, rather than the case on the left, which is chronic microvascular, where there are no cortical or juxtacortical lesions. Review question 2, a little bit more complicated. 3 choices now. Which one is the demyelinating disease? Well, A is Sussac's. Remember, that's the microangiopathy with mid or central callosal lesions. B is chronic white matter ischemic changes, where the lesions are not actually in the corpus callosum themselves. They're more in the deep white matter. And C is our multiple sclerosis or demyelinating lesion, the correct answer, because we have the lesions in the callosal septal interface along the undersurface of the corpus callosum. Final question, 3 choices. Which one's the demyelinating lesion? C, that's our peripheral enhancing, complete peripheral enhancement glioblastoma with inner nodularity and irregularity. B is the immunocompetent lymphoma, where there's solid periventricular enhancement. And A is our demyelinating lesion, where there's peripheral incomplete enhancement of the large lesion. I'd like to thank the contributors to these talks. Thank you.